Hello and welcome. Perhaps the biggest fallout of this coronavirus pandemic is the coming together at the same time of three great uncertainties. Uncertainty about the virus, uncertainty about the economy, and uncertainties about the science of this pandemic. When these three big global uncertainties come together and occur at the same time, we look towards and turn to the greatest of our global minds. One wonderful outcome of this, actually our frightening and unknown future, unknown is the key word, is that global minds across the world from different disciplines have actually come together like never before, believe me, united in tackling and solving this crisis. We need to listen to them and to understand and to act based on their findings. Even if there's uncertainty involved, they do the best job in an uncertain environment. Today we are lucky as we have some of the finest minds who have spared their time at this terribly busy juncture to talk to us. It's a rare gathering of different types of disciplines. Speaking with us tonight, for example, is Siddharth Mukherjee. He's New York based, of course. He's a physician, a biologist, an oncologist, and an award-winning author, including the Pulitzer Prize for his book, The Emperor of All Maladies. He's been listed as one of the 100 most influential people in the world and is considered to have transformed the public discourse on human health. We're also lucky to have Gita Gopinath, economist, currently in fact chief economist at the IMF, currently also professor at Harvard on leave to the IMF. Then Professor K. Vijayaraghavan, brilliant mind, principal scientific advisor to the Government of India, is a professor and former director of the National Centre of Biological Sciences. Also joining us from England is Dr. Chand Nagpal. He's chair of the British Medical Association Council and fellow of the Royal College of General Practitioners. Professor Prannoy Roy, he's Professor Emeritus of Economics at the University of California, Berkeley. He was formerly Delhi School, I have to say that, but also of LSE and MIT. Then we have Professor Lalita Ramakrishnan, a microbiologist, currently Professor of Immunology and Infectious Diseases at Cambridge. Her speciality is the amazing work and the study she's done on tuberculosis, including so much work in India. And we also have Professor Dev Sridhar, very influential at this time, a professor and chair of global public health at the University of Edinburgh. We're very lucky to have all of you. Thank you all for sparing the time to join us. Now, if we move on, let's start with some relatively good news. Let's look at what's happening to India. Let's look at a graphic on India and what's happening. Basically, we are updating our previous graphics and the lockdown is working. Just look at this. After the lockdown started, it went to a peak. That's the 2-week delay of any virus. You get infected and then it really manifests itself 2 weeks later. And then after 2 weeks, that sharp drop, that's the lockdown effect. And now we are at the lowest level of the rate of infection since the lockdown, the lowest level, around about doubling every 6 days. And at one point, it was doubling much, much faster, as you can see, almost every 3 days. Now, what about state-wise? Is this just an aberration of everybody's all over the place? No, not really. States are following a similar pattern, although there's variation. And in Kerala, let's start with that. The most successful state has attacked coronavirus even before the lockdown. And just look at the impact that has had. It started doubling every 3 days. Now it's doubling every 50 days. That means the infection rate is doubling every 50 days. That is very, very heartening. And that's probably because social distancing started even earlier and the discipline. One rather surprise and a good turnaround is Punjab. Let's have a look at that next. It really went through a worrying peak infection rate not so long ago, but it's been a major improvement. Just look at that. The lockdown starts, it went up to doubling every 3 days, then it came sharply down, and now it's a major improvement, doubling infection, doubling every 30 days. Let's go to whichever the next state we're going, Andhra. Let's go to Andhra. Here we are. The death rate is 3%, which is about the all India average. It hit a real peak, and then the people of Andhra really worked on it. The impact of the lockdown has been fantastic. Let's have a look at Telangana next. Telangana, lockdown, also a major success after a very dangerous period. It then has come down fairly sharply, and at the moment it is really, really, really low. So the infection is not spreading in Telangana at the moment. Look at this pattern that we're repeating state after state. All this is based on official government data. Let's move on to the next state, Tamil Nadu. That had a lot of bad rumors and information, but it has also come down pretty sharply after a peak. Look at that. Right down to near, the lowest it's been, certainly the lowest it's been since the lockdown. All these cannot be coincidence. They replicate a certain pattern, and it's quite reassuring. Let's have a look at Odisha. After they really had a frightening spurt, and then there was a major lockdown in Odisha. The government really clamped down, and tremendous success. Again, almost down to the lowest it's been ever since the lockdown started. What about Delhi? There was a bit of a worry. It came down, it started going up again, and then back again. There's been an improvement. Just look at that. It went up, came down, went up a bit, and now it's come down again. So Delhi too, first the lockdown effect and then the social distancing, the similar pattern. Most states are now finding they're at about the lowest point they've been for 3 weeks at least. Let's see Karnataka. Karnataka has been one of the successful stories. I must say that it has just, like Kerala, declined, but perhaps not as much as Kerala. It's still a little more way to go, but look at that. It's just they didn't really even need the lockdown. They had started social distancing, or maybe even a kind of lockdown 3 or 4 days before the actual lockdown. So Karnataka is heartening as well. What about Bihar? Here it needs more testing. Bihar is not enough tests being done, but again it was a bit worrying the last time we showed you. It's that spike towards the 3rd week that went up, but again that's come down, and little bit upward trend in the last couple of days, but it is again a positive feeling compared to even 10 days ago. Let's move on to the next state, which is Uttar Pradesh. Uttar Pradesh, there was a worrying uptick. It had come down, then it started going up again. Just have a look at the graph. See it come down, then it goes up, but now again controlled, it's come down. I don't say controlled, it may be temporary. These are just 3-4 days, 5 days, but it's very heartening that upward trend towards the end did not continue. So that is a major change in a huge state. Maharashtra, we all know that one of the things about Maharashtra is excellent testing, highest testing rate in India, and you have to commend them for that. So as a result, they have had a pretty tough time, and it's still not quite controlled the situation. But look at the last 2-3 days. After a terrible cause for concern, it's really come down to the lowest it has been since the lockdown. Rajasthan, let's have a look at that. We've got 1 or 2 more states and that's it. Again, the lockdown was successful, and there's been again a welcome improvement in the last few days after a worrying bit. See, it had started going up and you thought, my God, if this carries on, that will worry. But then control, come down. But how long this is, we must have a proviso that all these are very little bits of data, 2, 3 days, 4 days, and things can change. But this pattern so far, all of them, is to some extent really reassuring. What about Madhya Pradesh? Lockdown has been successful, but the infection rate is still not low enough. Look at this. Madhya Pradesh is, gone up a little bit. It's a little bit worrying. It had come right down. I don't know whether people got lax or what happened, but that we hope that when we update this a week or so from now, that trend will come down again. It's very important. It's too high at the moment. And West Bengal, the lockdown was very successful. The problem with West Bengal, it needs much more testing. It did hit a huge peak, a lockdown worked, and then it's been kind of flat, but slight trend downwards, and it gives a lot of hope. But more testing is needed in Bengal, definitely. But it's a positive outcome. Now, Gujarat was really one of the big worries. But there's been an improvement in the last few days. But still, even with that improvement, it was so bad earlier that the level of the infection rate is still worrying. Let's have a look at Gujarat. How is it went? You see, it was going fine, and then that spike up, and that really scared everybody. Now that seems to have come down, but you look, the doubling rate is still not absolutely perfect, and maybe that trend downwards will continue, but compared to a week ago, this is a big relief. Now, one of the things, and our first panelist is a wonderful Siddharth Mukherjee. And he has come out with a theory, an analysis that don't just look at who's got it, who's infected, who's not. It's not like everybody that's infected is the same. That everybody has a different viral load. It's for many illnesses. So let's just, before I ask him to join us, let's just look at what exactly, in simple layman's terms, what a viral load means. The viral load is what matters. Not all COVID-19 infected people are exactly the same. It's not a binary thing. You've got it or you don't have it. It's not like that. Let's take, for example, 3 coronavirus patients. One with a low viral load, one with a moderate, and one with a high. Now, the low one will have few symptoms, could even be asymptomatic, which is worrying because he can still be infectious. So that's the low viral load, and even after that, you get better fast and you can go back into society because you have some immunity. The moderate level of viral load is where there are clear symptoms, which means you get fever, you have a cough, and you have tiredness. These are 3 most common features. And that needs to be treated by under doctor supervision, not necessarily go to the hospital. But of course, if you get a severe viral load, you've got a bad attack, what we say in layman's term, then you've got very, very serious symptoms. And at some point, you may need respiratory care. It may not be a ventilator, that's an extreme, but some kind of breathing help in various ways. So these are the 3. So it's not you've got it or you don't have it. It's how much you've got it and how badly or how little you've got it. So let me welcome the outstanding Siddharth Mukherjee. The big new factor, Siddharth, that you have brought into focus is that the load of the virus in you, the viral load you call it, is crucial in determining how sick you will get. If you have a huge load, that means you have a severe amount of coronavirus in you. Perhaps because you've been exposed to it more, maybe to the same person in the family or anywhere many, many, many times. And with a high viral load, you could get much sicker. On the other hand, A little bit of exposure means you could get low level of viral load, which means you could get mild sickness, you could recover quickly. So basically, am I being simplistic that the amount of virus coming into you is important? Is that right?
That is correct. Now we don't know this for COVID. We know this for most other viruses, including SARS, which is a very close cousin of COVID. So let me be very clear. No one's done this experiment for this particular virus, but most viruses behave in this way. Now, what I should also mention is that, and it's also described in the article, that it's the load of the virus and it's your host immune system. It's a combination. So it's really, as I said, it's like a battle. And you can think of the virus, imagine the virus as radiation, or imagine the virus as a poison. The amount of poison or the amount of radiation determines how sick you get from exposure. And it's very similar to viruses. The only difference in this case, of course, is that your body is also is part of the equation. That part of the equation we don't know yet. We only know that elderly people and people who have immune systems that are already depressed have a more severe likelihood of dying from this virus. But we also are getting to understand that the amount of virus, the dose, is one crucial element of this response, although we don't have firm data yet for this particular virus. We do have it for many other viruses. And so one of the crucial things is to reduce the dose. And the way to reduce the dose, as I said already, there are many ways to reduce the dose. But I encourage my patients or people who are thinking about this in public health, imagine the virus, as the size of a football. And imagine that there are hundreds floating in the air. The amount of times that you will, and imagine that every time you hit a football, you get knocked back down a little bit. If you hit one or two, you will survive, you will bounce back. But if there are thousands coming at you, then of course you will fall down. And that's the situation with the immune system. The virus, is just a microscopic version. It doesn't float in free air, so don't make that mistake. This is just a conceptual experiment. The virus floats in respiratory droplets, in cough droplets. And your job is to reduce the exposure to these cough droplets or to the outbreathing of people who are breathing out while they're actively shedding the virus.
Right. Thanks very much. We'll come back to you several times over the next hour or so. If we can speak to Gita Gopinath. Gita Gopinath, thank you so much for joining us at this really tough time for you. As an economist, we always know economic policy and any economics is full of uncertainty in decision making, and we have ceteris paribus and various other conditions. Everything should remain constant. But now not only do you have the uncertainty of economics, you have a pandemic virus with even more uncertainties than economics. I never thought that would ever happen. So many countries have a financial crisis. 100 or so have come to the IMF. How are you and the IMF going to handle this crisis?
So, hi, Prannoy. That number now is actually slightly over 100 in terms of countries that have approached the IMF for financing. And what we are doing is we are rapidly responding to that. We are providing what we call rapid financing facilities to several of the members that are approaching us. We figured out that this would require about $100 billion in terms of financing needs. And to make that happen, we've kind of doubled access to rapid financing facilities. And so, we're deploying our $1 trillion capacity that we have to serve the needs of our members at this time. But the demands are really unprecedented. I don't think there's been a previous time when we've had 100 countries come to the IMF.
Yeah, it's just amazing that. And, it's just how you're going to handle it is just a marvel that you can all work so hard, again, under these conditions. Can I just ask you, is India one of the countries that's applied to the IMF for a loan?
No, we have no inquiries from India.
Okay, we'll come back to you and ask you more questions exactly how you're handling this global crisis country by country. We'd like to call Vijay Raghavan, Professor Vijay Raghavan. Sir, basically, we want to know from your understanding, and simplified as you're so good at doing, how did this pandemic start? Because we learn from that. And how is it spreading, or how do pandemics generally spread? And basically, what can we do to reduce the impact that a pandemic has on our lives?
This is a very important question, and there is a narrative in the public which is, which makes for a good story, that someone went to a wet market in the Hunan market in Wuhan and bought something, a bat or a pangolin, and by maybe touched their nose or face after that, and then the whole thing started. Now, this may well be true as a matter of fact, given that we know that there was one spillover event. But it would be wrong to assume from this that if that event had not happened, there would not have been a pandemic. Pandemics happen because these kinds of events are made more and more likely, or there is a prolonged period during which such interactions occur, and therefore, over time, even though there's an event of very low probability, over a long period of time, such a low probability event happens. So yes, it did move from an animal such as a bat or a pangolin to a human, but it's not just one off event. It is the interactions have been going on for a very long time. And indeed, it looks like bats and humans have cohabited in many ways right through human civilization. Now, the related point is, why do bats have these kinds of viruses in such large numbers? And that was discovered in 2003 by epidemiologists and people who study evolution of these viruses and zoonotic jumps from animals such as bats to humans. In 2003, people explored bat caves and bat markets in China and discovered a huge range of coronaviruses in them. And since then, coronaviruses of this kind have been found in bats all over the world. So this is a very important scientific discovery about this. So the question is, if these bats harbor these viruses, how come they are not affected? And that, again, has been an area of study, and much new information has come on that over the years. And that's because these flying mammals are powered, use so much energy in flying that they need to downplay the inflammatory response in their immune system so that they can handle the metabolic activity required for flying and not get constantly battered by infection by over-responding to them. And therefore, bats, by this accident, have become an extraordinary experimental laboratory for these viruses, many kinds of coronaviruses, to sit together, exchange genetic material, and make newer kinds of viruses without harming the bats themselves. Now, these kinds of coronaviruses, bats aside, they also cause common colds, which infect our upper respiratory tract. Unlike the severe acute respiratory syndrome, SARS, and the MERS, Middle Eastern Respiratory Syndrome viruses, which infect our lower respiratory tract. Those cause extremely severe fatality, a high fatality rate, but they're not easily transmissible. Common colds are easily transmissible, but they don't have a high fatality. What SARS coronavirus has done in a very insidious manner has merged transmissibility with this fatality, which is very high. And therefore, it is particularly lethal.
That's really fascinating, the combination of high fatality and highly infectious is what this COVID-19 is all about. And what the other thing was mind-blowing, and you explained it so clearly, that bats tend to downplay the system reaction to the infection. The problem with humans, that's the opposite of the problem with us humans, that we over-respond to this virus. And that causes greater illness. Is that right, roughly?
Well, because what happens is that first, when the infection comes in, the immune system, by a variety of ways, by the virus, is suppressed in a very light touch but effective manner. So many people don't respond well. But then, as the virus overwhelms the body, the immune system kicks in with a huge number of viruses, and it does so with such non-specific ferocity that it affects both the virus as well as us. And that's the cause of many of the severe problems. Now, how does the virus get in? And that, again, the bat has served as an extraordinary laboratory. It has experimented, the virus has experimented to find the perfect fit between lock and key so that some things on the surface of our cells provides the entry point for the virus because it matches perfectly with the tip of the virus's protein. And we know what those virus protein tips are and what those entry points are. Those entry points are those involved in our blood pressure, in our hypertension pathway, and those proteins are expressed in our kidney, our lungs, and many other tissues. But the virus uses it entry from our respiratory tract. So this, again, is an enormous evolutionary process, slow but steady, where the lock and key fit has been done in extraordinary ways.
Interesting you said that we've actually lived with bats for, hundreds of thousands of years. In fact, I've seen Attenborough in a cave full of bats and all of them flying around, and his whole clothes and his jacket became white because of bat droppings. There were so many, and nothing happened to him. So I'm going to ask you a silly question now that we know a bit about bats and this coronavirus, bats to pangolins to humans. But if you're walking around somewhere and it's getting a little dark and bats are flying around, that happened to me not so long ago, should we be terrified that bats flying around? Should we all, duck and be really frightened or not?
Not at all. Just as, one shouldn't be terrified of any one given part of an entire, family of viruses or bacteria because one small part does something. Similarly, one shouldn't be afraid of all bats because some bats harbor this virus. Bats are extraordinarily valuable in our ecosystem. They're pollinators. They do wonderful things in terms of, preserving our biodiversity and our ecosystem. One shouldn't have them as pets. One shouldn't get them close by. One should wash, fruits where the bats are likely to interact. You shouldn't pick up and eat half-eaten guavas by bats and so on and so forth. So care has to be taken, but certainly, bats are not, dangerous in that sense at all.
Well, that's good to hear that, actually, because, we've always, any animal, you wouldn't eat a half-eaten fruit from any animal. So treat them with care, just like you have done all these years. Nothing special that bats have to be killed or anything. Just one other clarification that we're talking about animals. Dogs and cats who are pets, is there any danger from them? Any danger at all?
Well, there have been some one or two instances where it's been suggested that cats could be infected by SARS coronavirus 2. There's no evidence at all, one way or the other, whether they are, sources of transmission. Doesn't seem likely compared to the human-to-human transmission which is going on. Typically, when you have human-to-human transmission, that dominates. You don't have a back and forth thing between other animals as a dominant way. So right now, the evidence is not in favor of that being a substantial.
So that's really good to hear, and it's very important to know because so many rumors are flying around. We must understand dogs and cats cannot give you coronavirus. Please do not believe WhatsApp, fictitious and fake messages. Now, if we can bring in Dr. Devi Sridhar right now. Thank you very much for joining us. It's a real privilege to have you with us on this program. One amazing thing that you had actually flagged this very possibility of a pandemic from a virus originating in China. You flagged it 2 years ago. You gave a talk on it. And you said it may spread around the world. It won't stay in China. That's just incredible. In 2 years, it's actually happened. What led you to believe and give that talk about it 2 years ago?
Yeah, I think there was always a worry that the animal to human jump of a virus was probably the most fragile part of health security, and that a number of the viruses and the challenges we faced in previous years have come from animals, whether it's birds or pigs or bats are also a very common reservoir. And so I guess the thinking was that, the largest threat across the world would probably be one of these viruses that are circulating in the animal kingdom, making a jump to humans, and then being able to sustain human to human transmission and transmit quite easily. And respiratory pathogens are the hardest one to manage because it spreads like a cold or a flu. And so, yeah, that's kind of what we were anticipating and hoping would not happen, but has happened.
Yeah, it's amazing that you even thought about this when everybody else must have said, oh, that's you're exaggerating, but it's actually happened. So could you explain, as you've been just talking about, just exactly how this coronavirus is transmitted? People are saying it went from a bat to a pangolin to a human being. What is it? I mean, there's so many different theories. What's the best estimate? I know everything is not certain right now. What's the best estimate of how it actually happened?
Yeah, I think the scientific community is pretty sure this came from a bat because coronaviruses generally originate in bats. And I think at some point it jumped to an intermediary animal. Their guess is that it was a pangolin, but that has not been confirmed yet. That's what we're waiting to hear. I think the most challenging thing about this virus from a public health perspective is that you can have both pre-symptomatic transmission, meaning before you feel ill for about 5 to 7 days, you can be spreading the virus to other individuals, as well as there seem to be asymptomatic carriers, so people who feel fine, but who are just carrying the virus and might be infecting others. And so this virus is particularly hard to control and to contain because of those elements.
Yeah, thanks very much. We'll also bring in Dr. Chand Nagpal. Thank you very much for joining us from the British Medical Association Council. We are responsible for so many doctors all across England, and you're fighting hard for their safety and for looking after them. We found these reports, I don't know if they're correct and whether you could actually clarify this, that a lot of British Asian doctors, that Indian doctors or Asian doctors generally in England have been a higher proportion of deaths. Is this proportion higher than the norm for all doctors? And is there any particular reason why more British Asian doctors are dying than other doctors?
Yes, so the first 10 deaths in the UK, the first 10 doctor deaths, were all from black and Asian minority backgrounds. And all of them, except one, has come from overseas. And this is particularly tragic and sad because these are doctors who have come to the UK, they've given their lives to the National Health Service, they've saved others' lives, and in the process, they now have unfortunately died. We also have a far higher proportion of ethnic minority patients who are hospitalized in the UK. About 33% of intensive care beds are occupied by patients from ethnic minority backgrounds. Twice as many Asians are in hospital in intensive care beds compared to white patients. And we occupy only about 13% of the population. So disproportionate effect on Asian and ethnic minority population and also doctors.
Why? That is a bit of a worry. Why is this happening? Is it a worry for all Asians in general? Should we in India be worried that we're a little more prone to it? or is that an exaggeration? You can't really extrapolate from what's happening in England to here.
Well, it is certainly a worry. These statistics are concerning because it's a new virus. It's a novel virus. No one can actually say we quite understand why, but we are looking at it, and I've called upon the UK government to urgently investigate and take action to mitigate the impact on our Asian and black population. Now, one of the reasons that has been put forward is that many of our Asian populations do suffer with what we call comorbidity, higher levels of hypertension, higher levels of coronary heart disease and diabetes, which added together places a person at much higher risk of the infection having a more serious effect. What we're looking at now is whether we should stratify ethnic minority doctors and protect them from front-facing care of patients with COVID. That's what's being looked at. That's one possible reason. Another factor that is of concern is that in terms of our key workers, so we have a lockdown in the UK like you have in India, but hundreds of thousands of people still have to work to keep shops open. We still have our transport still functioning, so bus drivers, train drivers, care homes, and of course healthcare workers. Now those key workers are mixing with others. They can't be at home, so they're probably more exposed to the virus. And as I said, a larger proportion of our key workers are from ethnic minority backgrounds. And that may play a part as to why the infection is affecting ethnic minority population greater. There's a third factor, which is in the UK's overcrowding. The proportion of our ethnic minority population who are in overcrowded houses is far greater than the white population. And as you know, we live in extended families with multi-generational households. So you can have younger members of the house going out to work, doing essential work, coming home and spreading infection in the same household, especially the older population in the household who may be vulnerable with lots of other medical conditions. Another reason why we think, there's another reason why we think this is happening is also because of the lack of public health messaging being understood by some of our ethnic minority communities.
Right. It's very interesting that it's not, what you're suggesting is not really something genetic or some inherent problem. It could be other issues like diabetes. It could be that they're frontline workers, so they're infected more, and also they're in joint families. Very, very interesting. We'll be coming back to you. Meanwhile, let's bring in, we're talking about the virus and the economics of it and the science of it. So couldn't get a better person than Professor Bardhan, Prannoy Bardhan, joining us from Berkeley, California. It's really great to have you. You, as usual, have been following what's happening in India so closely. You've always had this amazing passion for India. Now that we're in a lockdown, what is your overview of what is happening at the moment in India? Are we doing well? Are we handling it properly? What's your view?
I think what needs to be done have to be classified into various forms, like what needs to be done immediately, and then some things in the medium to long horizon. What needs to be done immediately, because of mistakes that have been made, particularly with respect to the declaration of the lockdown without arranging for enough food and shelter for the migrant workers and the suddenly unemployed people. But now that has happened, the tremendous amount of dislocation and destitution that has happened. Immediately, I would suggest three things. One is, of course, I think it's already started, various kinds of community kitchens all over, wherever it's possible. But apart from community kitchens, the other thing I don't see much discussion of in India is, I think it's high time that we start on the lines of the the Mahatma Gandhi Enriga in the rural areas, we need now a similar program in urban areas to put back to these people on work, because they are going away not voluntarily. But for the formal sector workers, medium to large enterprises, also, instead of laying off people, what they should do immediately is something that France and few other North European countries are doing, namely prohibiting all layoffs. And in exchange, the government is providing wage subsidies. So in other words, for example, in India, a very large percentage of workers, of course, even in factories, are not regular workers, they're casual workers. Contract workers. So if immediately the government announces that no layoffs either of regular workers or contract workers, and in return, the government should provide some wage subsidy for anybody who's in the payroll. That should help the company, the employers, to keep those people in the labor force. There is one big advantage of that, and this is the main reason, one of the main reasons that Europeans are doing it, is that as and when the economy tries to get in shape back to normal, it's easier to people who are already on the payroll and getting wage subsidy, so in some sense working, to get them back to normal is much easier than if people get laid off and then hired back again. That's much more time consuming. It creates more dislocation and, of course, mental distress. So altogether, I would mention these three things that I mentioned. The first two primarily for the very poor in the informal sector, and the third is primarily for the formal sector.
Right.
These three at least should be done immediately.
Yeah, let's just go back in a moment to science, and we've got Lalita Ramakrishnan with us. Thank you very, very much for it. You have done so much work in TB, and you've been studying global trends in the spread of coronavirus. India appears to have been hit later than other countries. Can we learn from the mistakes of other countries and maybe learn from the positives that positive steps that other countries have taken? We're lucky to have it a bit later in that sense.
Yes. So, you're absolutely right. India is in a way in a good position because it's come relatively late to India, and actually India's numbers are looking pretty good at the moment. You've got about 400 plus deaths, maybe about 450 so far, and maybe about 10,000 cases. So there is time to do some mitigation and to prevent things from going out of hand. With any luck, maybe they won't even go out of hand. Right.
We'll come back to you with more details on that, but let's just get back Siddharth Mukherjee. We had talked about viral load and your very important article that you've written about it. But what difference does it make? Does it have a lot of implications for treatment? Because if you're diagnosed with a heavy viral load at the beginning, that means you should be treated extra carefully. Or if you're very light load in your initial nasal swabs, you can be asked to stay at home and be in quarantine. Does it affect treatment, the extent of your viral load in your tests?
Exactly. So triage is a very important aspect of this virus. And by triage, we mean, how to take care of the patients. It would be very, very helpful for any situation, any country, if we could tell upfront from a simple measurement, not just whether you're infected versus not infected, but whether you're carrying a very high viral load and you're shedding a lot of virus. In that case, you're likely to have a more severe course of disease. And in that case, you're likely to need more attention, more follow-up. So we could divide people up into the people who are shedding a lot, have a lot of viral load versus people who have little or less viral load. Now, this is what we used to understand and treat other viruses such as HIV, quantitative viral load measurement. These tests are not available out. These are experimental tests still. But if we decide that we need to optimize the use of resources, limited resources, such as ventilators or even clinical trials for antibodies, these measurements will become very effective because they will allow us to determine who to put on the study, who not to put on the study, how to best use the hospital resources that we have, the beds, the ventilators, and the nursing and the medical staff. That's
actually really crucially important benefit for all of us, being able to measure the amount of viral load. It's so important, that paper you've written. Now, apart from ventilators are in short supply, so you can allocate them better once you know the viral load in a test. Does it also have an impact on the kind and the strength of medication that you give a patient?
One very important idea that emerged from when we first began to try cocktails of drugs against HIV is the idea that the viral load itself is the right surrogate and by surrogate I mean by measuring the viral load, you can find out whether the medicine is working long before the patient even gets better. So it allowed us to make medicines and test them in clinical trials much more rapidly. So that's another advantage of being able to measure these things quantitatively. You can tell whether the patient is long before the patient becomes physiologically better. You can measure whether you're actually killing the virus inside the body or not. And that was a very big advantage, or a very big move in HIV. And we hope we can be able to do the same thing with coronavirus. It's almost certain we will.
Right. Since it's now absolutely clear that it's very important to know what the extent of the viral load is in each patient. It affects treatment, it affects how you segregate people. But now, finally, it's so important. How do you actually test and measure viral load in a patient?
Yes, there are ways. There are multiple ways to do it. Right now, we're doing this only in the experimental setting, but we will eventually start doing this in a clinical or a treatment setting, and so so those will be very important.
Right. Okay. Well, coming back to India, we have this lockdown, which, according to all data, seems to have been a success. Perhaps the lack of notice of it and the terrible impact it had on migrants was an implementation issue. The fact that it was in lockdown was a great success, has been so far. Let's always be very careful what we say in this uncertainty. In that sense, it has slowed down the pace of the virus, but we are going to wait for a vaccine, for this to be to be able to be free and say, look, I've had a vaccine, I won't get that. What does science, technology, and economic perspective, how do we save lives and livelihoods while we wait for this vaccine? We need a careful way out of this lockdown, a path that is not reckless either.
Absolutely. While I'll answer that, let me add one more point to how wonderfully our research and education system in India has coped with understanding the disease, its epidemiology, and its growth. And that's because over the years, we have trained biologists, field epidemiologists, ecologists, geneticists, population geneticists, IT professionals, people who can handle data. And all this means that India is one of the few countries where we have an extraordinary depth of understanding of what's happening here, and the ability, which I'll answer your second question, to actually deal with the problem because of this integration. We need a lot more of that, but it shows how valuable our investment in research has been, because it's allowed us to deal with something unknown, which has come upon suddenly in a manner which very few other countries can. So that's really the wonderful part which we have to keep in mind. Now, your second question is about how does one relate the lockdown and its release to both lives and livelihood. And this, is wrongly posed, in my view, as a dilemma between lives or livelihood. It is, also wrongly posed as a dilemma of every life is absolutely valuable to, okay, let's open up, and it doesn't matter if a few thousand are in trouble, we'll at least have the economy back in shape. Such false posing of questions makes the answer to the problem elusive. The problem is a simple one. You have a virus which has got very interesting properties. We don't know too much about it, but we're learning every day hugely. It transmits from person to person, even when people are asymptomatic. We know that. So looking at people who are simply symptomatic and dealing with them is no use, because while you're doing that, asymptomatic people are transmitting. Therefore, if you want to have lives and livelihood together, there is only one way by which we can do this while we await drugs or vaccines, which can take their time to be perfect. It'll come soon, but we have to get going right away. And what we need to do in the meanwhile is contact tracing, testing, and tracking. What does this mean? Over many years, we have done really excellent contact tracing in diseases which are endemic in our population. Polio, smallpox, rotavirus, and so on. When we introduce vaccine programs, we follow everyone and find out have they been vaccinated or not. That's a slow, steady, superbly efficient manual manner. Today, what we need to do when the disease is exponentially rising is to have this kind of contact tracing at really warp speed on a day-to-day basis. Can we know when someone is positive, who all were in contact with that person in a manner where transmissibility was likely over the last 10 or 15 days? Can we find out all those people, help them be isolated or quarantined so that they are not put into the work system while as others can go ahead? This is possible only by a combination of manual contact tracing and digital contact tracing. The government has brought out Arogya Setu, which is a digital contact tracing method. There's one for smartphones. The feature phone version is coming out. And if in a shopping mall or in a railway station, if about 90% of the people have these features, the feature phone version, the app version, and are linked to community workers, then should one of them turn out to be positive a few days later, then depending on the proximity, the others can be attended to, allowing others to go into the working. This is incredibly important. It combines the simplicity of manual contact tracing with digital and allows the workforce to have bridges to cross infected areas and go into work. And this can be incredibly valuable for this pandemic and also for other kinds of pandemics.
Absolutely spot on. It has such an important, everything you just said, strong implications for the economy, because if we don't have a clear path and a careful path out of this lockdown, the economy could suffer, not just India, but across the world. Let's ask Gita Gopinath. Gita Gopinath, what would you advise emerging markets to do? We don't have the luxury and the wealth of developed countries. What should an emerging market like India do?
So firstly, Prannoy, given how exceptional this crisis is, and given this is what we call a truly exogenous shock, that countries should do the spending that they need to do. So we would expect to see countries running bigger deficits than they have run in the past. Now, the question, of course, is that how much can they do, and how much is affordable? So that depends upon the borrowing costs that countries face. There are still many even emerging and developing economies that have access to markets, domestic markets and international markets, that can borrow at reasonable rates. And so that's one option. But I think what will be needed as this crisis unfolds is much more concessional financing provided by international institutions. Secondly, it will need aid for many countries. And third, it will need debt relief in general for many poorer nations who at this point are making choices between whether to service their debt or to, take care of the health of their people. So it's going to require both more on the fiscal front in many countries and also being supported through international lending of various kinds.
I get the point you're making, and if I can just ask you to be a little more specific, what do you think kind of the level of fiscal or this budget deficit that emerging markets are going to hit, especially for someone like India? What should be the percentage of GDP that we should be spending? How far should we go?
So, Prannoy, this is going to vary across countries. The way this crisis hits different economies obviously is not uniform. I also would be a little careful about comparing fiscal spending numbers because, some of it are above the line, what we call, or below the line, which is some of it is literally fiscal transfers and spending, and some of it is more credit guarantees and loans, which are not exactly do not get into the fiscal deficit numbers. So it's hard to make that, a comparison. The way we've looked at the policies that India are doing, firstly, we really commend the government for, putting the lockdown in place to contain the spread of the virus. And also, they've been good about targeting the support that they have provided in terms of, getting cash and non-cash forms, food in-kind transfers to people and support to small and medium enterprises. I think what we would say is that the scale could be bigger in the sense that more can be done. And India certainly has the ability to do that, and I'm sure that's being considered. But that would be one area that we would go is in terms of the scale of the interventions.
That's important. That's the scale should have been bigger because the lockdown has been a success, and it's great that we did it early and we stopped foreign travel from coming in very early. That was a great decision. But then without warning, without any implementation finesse, when you look at the migrants, don't you think more money and food and should have been spent on helping the migrants and forget about fiscal deficit for a while?
So just again, 2 points. One, like you mentioned, countries have to do containment measures, but at the same time, when they're doing the containment measures, of course, they have to do what's needed to protect people and their livelihoods. And of course, in India, there are many daily wage workers, and you have the migrant workers. So the scale of it is even bigger. The second point is, yes, India can do more in terms of on the fiscal side. It can provide more support. I'm sure the government is thinking about it. I think what we have to keep in mind is that there is always a concern. Okay, as you run bigger deficits, is that going to now bring in scrutiny and other kinds of problems? Now, this is a global shock. We are seeing countries across the world spending. India is no different. Countries are running bigger deficits, and again, India is no different in that matter. So I would expect to see a greater in terms of scale of the support. I would expect to see that go up.
Okay, let's hope that's coming. But Gita Gopinath, you know the Indian economy very well, and you've studied, and you've been here, you've worked with the Kerala government. Very quickly, what step should India take immediately and then say in the near short-term future?
So Prannoy, the steps I will mention are the following, which is one, the priority, of course, has to be health, people's lives. So that would require spending in the health sector. And, it's not just now, but going forward, a much stronger health infrastructure is needed. But for this crisis, of course, it's going to call for even more bigger testing capacity because I don't think this is going away anytime soon. And if you want to resume activity, there's testing, contact tracing, all of that will have to continue. So that's one bucket. The second bucket is getting money into the hands of people who at this point, just have no income and they cannot survive this crisis. And that has to be done at a scale that's appropriate given the crises that the country is facing, pretty much all countries are facing at this time. For small and medium enterprises, also support has been provided to them. I think it's very important that while you ramp up the fiscal spending, that you keep the receipts, which is to be very clear and, in terms of accounting for all the spending that's done, a very transparent accounting of it, both that's off budget and on budget, so that once we are past this crisis, the necessary steps can be taken. And then on the financial side, of course, monetary policy support, we expect more of that to come, given the forward guidance of the RBI. But again, also, while you're putting all this liquidity in the system, you also want to make sure that you have the right regulation and supervision to at least keep an eye on, the problems that could be building up in terms of non-performing loans in the financial sector. So these, I would say, are some of the steps. And once you're in the recovery phase, you could think of a more general fiscal stimulus, which is on, infrastructure and infrastructure building by the public sector, which could also help growth.
Move on to infrastructure spending later on in the shorter term, once you're getting out of this crisis. Since this program is going into everything in some depth, let's just stick with the economy for a moment and ask Professor Prannoy Roy again. Gita Gopinath says India has to scale up in terms of how much it spends, and the fiscal deficit is not absolutely urgent right now because this is a global crisis. But India has so far spent about 0.85% of our GDP as a stimulus package. Do you think we need to spend more, or could that be dangerous as well?
I think that in terms of percentage of GDP, the government, the finance minister announced what she said 1.7 trillion rupees, which of course is, as we know, only about half of it are new expenditure. So I think it's more like a little less than 1 trillion rupees. I think the actual need, immediate, is many times that. In my judgment, at least 5 or 6% of GDP, if you think about not just the migrant laborers, but also not just the people who are below the poverty line, let's roughly say about 20% of the population below the poverty line. But about 30% above those who are above the poverty line are also very poor and now struck by this crisis. So that's about half of the Indian population. And in order to do something for them, 1% of GDP is not enough. At least 5 or 6%, which will come to a little above, say, 10 trillion rupees, 10 lakh crores. So I think a very much larger amount is needed on the immediate issues, and particularly the three kinds. Just to remind you, one is immediate feeding these poor people. Second is the an urban public works program. And number three is the wage subsidy program, not to lay off people. If you take all these three and plus the government announcement of putting money in the Jan Dhan, which I think is again extremely small. I think Jan Dhan announcement was 500 rupees per month. You really need a much larger amount, and not just for women. All this put together, I think we need probably 10 times what the finance minister has announced. If I assume the new expenditure as 1 lakh crore or 1 trillion, we need at least 10 trillion.
Really interesting. Okay, for a moment, let's get back to the science and the medical aspects of the coronavirus, because they impact the economy so much. If I can ask you, Lalitha Ramakrishnan, you're a global expert in tuberculosis, and you've worked on it for years in India, in fact. Are there any similarities, anything to learn, any lessons from how to handle TB and use some of that, some of those methods or learnings for COVID-19?
there are many similarities. The obvious similarity between COVID-19 and TB is that they both spread by the respiratory route. So you have people basically breathing out the infection. Now, that immediately brings up a point that's quite pertinent to India, which is that who is more likely to get these infections? Both of them. People who live in overcrowded, underventilated situations are by far going to be the ones who both get it and, in the case of COVID-19, spread it.
Yeah, those sort of factors that you're mentioning are really worrying. And, we keep wanting to know, are there any lessons we can learn, what to do, what not to do, given past experience and other types of illnesses. But, you never know whether they'll really work or not, and you may make a mistake if you just copy what you did. But what are the differences, to put it simply for a layperson audience, between TB and coronavirus? And what makes the coronavirus even more worrying in terms of the spreading of the disease than TB? Is it more worrying or not?
Now, there are a couple of differences between TB and COVID-19. One thing is that, infections spread by something called droplets. That's, when you sneeze, or even when you talk, you can get these big droplets. They're not ones you can see, but they're much, much bigger than the very fine droplets that spread TB. And those fine droplets, they're actually not even really droplets. They're called aerosols. And so COVID is spread mostly by big droplets, and as a result, it's a lot more contagious than TB is. Now, the other commonality between these two is that most people with both COVID-19 and with TB have asymptomatic infection. In other words, most people who get this infection will never show symptoms and they'll just clear it. Yes, so that's true for both. Now, there's one big difference, though, that's emerged. People who are asymptomatically infected with TB never spread it. And that's because you need these cough aerosols in order to spread TB, as I told you before. However, in COVID-19, it's become very clear that people who have, who have no symptoms whatsoever, they put out droplets that contain the virus when they talk, when they sing, when they sneeze. So that's why COVID-19 is even more contagious than TB.
Actually, that's a very crucial point, that you can still spread it when you have no symptoms, you're asymptomatic. If I can ask Dr. Devi Sridhar, that's a huge difference, isn't it, between the coronavirus, COVID-19, and other viruses? This sort of asymptomatic, a person is perfectly normal, but can transmit or can be infectious, asymptomatic transmission.
Yeah, definitely. I mean, this is a large difference to SARS and MERS, two other coronaviruses that the world has had to grapple with. Because if you only have people transmitting when they're ill, it's obviously easier to catch. One, they're not out at, in society, on public transport, at social events because they're ill, so they're not able to spread it, but also they can actually identify themselves to public health authorities to say that they're unwell. And so I think this has probably been the most challenging part of this, because just telling people to stay home or to, go into quarantine if they have symptoms is only going to catch a certain number of people and not a large percentage who are still spreading it.
So how do you handle that? Given that you've studied different countries and the way they've handled this virus and other viruses earlier, some successfully, some not so successfully, how do you handle this virus and this factor that people without any symptoms are transmitting it? That's a real problem that we've not really faced before. What's the best way to handle it if you've seen how different countries have handled it?
Well, there's no easy or simple answer. I think what we've seen are components of a possible public health approach. One that's become clear is testing, and being able to have rapid testing of individuals so they know actually if they're carrying the virus so that they don't expose themselves to others and can go into quarantine. I think another is that you've seen exponential growth of this virus. So unchecked, if you don't put in any kind of public health measures, this will spread rapidly throughout a population and quite quickly. We've seen it with growth in world figures where, first we were talking about, 30 cases in China and now we're, over 2 million. And so I think it's recognizing that sometimes you need lockdown solutions, which is basically very harsh physical distancing to slow the virus, to bring down the rate of transmission. And then at that point, to try to actually just quarantine those who are carrying the virus instead of having to basically assume everyone has it.
Right. I just want to come back to Dr. Chand Nagpal. So you describe very well the possible reasons why Asians and Indians are getting more ill, and doctors are a higher proportion of Asian doctors are dying in England, and we're still trying to find out the real reason. Many of them could be social causes that you mentioned, overcrowding and not understanding exactly what to do in a different environment. But have we ruled out a genetic reason so far?
I think there's been a lot of people coming up with theories, such as whether it's vitamin D deficiency, there's something called the ACE receptor. They've not been proven, but what we can say is that we do know that hypertension, diabetes, heart disease, renal disease, these do contribute to a greater risk of the infection affecting you more seriously. So those are things we can automatically say are higher risk in our Asian community, and why there needs to be even extra effort to protect those at-risk individuals. At the moment, we don't have, for example, our Black and Asian minority population as a risk factor in their own right. It may be that we need to consider that as a risk factor which should be protected or shielded and not exposed to risky environments.
So, but just to push you a little bit on that, for people in India, given the fact that there's a higher fatality rate and higher infection rate among Asian population in the United Kingdom, should people in India be worried that this could be a weakness that we have, or is that there's no real connection between the two?
I think that there should. I mean, obviously, the socioeconomic arrangements in the UK are different than in India, but there should be concern because there is no doubt that having additional risk factors, medical risk factors, adds to the seriousness of the illness.
Right, that's actually, I think, pretty clear. Let's move on to one of the factors that's been a little controversial up to now, but now there's been a consensus in opinion, that's on masks. Should you or should you not wear masks? Many leaders in the West said it's a waste of time. But the data, if you look at it, just let's look at some of the graphs about how masks actually do make a difference. Mask wearing countries, you find, reduce viral impact, reduce the impact and the spreading of coronavirus. Just look at first countries which do not generally wear masks, like the United States, Spain, Italy, UK. That's the kind of trajectory that the number of people that get ill in countries that don't traditionally wear masks. Now let's bring onto that same graph countries that do wear masks and look at that, generally much lower. China, the difference with China was that they never had any warning. They didn't know what was happening. We all had a little bit of advantage because it hit everybody later. But look at the, Singapore and South Korea and all of these countries, the blue lines, wearing a mask does seem to make a difference from the data. I know we shouldn't just look at data. There's so many factors that affect this apart from masks, like testing, etc. But it's a nice little simple fact. And in fact, now the Indian government, if we can ask Siddharth Mukherjee a question on this, because you can't get a better perspective than with Siddharth Mukherjee. Because the Indian government has made wearing masks compulsory, Siddharth. even if they are homemade masks, they don't have to be the perfect N95. The mask doesn't have to be absolutely spot on. In fact, you should keep the best mask for the doctors and the frontline hospital workers. Is it that they reduce exposure and reduce the viral load for everybody? How would you put it? Is it beneficial, bottom line, definitely to wear masks?
That's what I'm saying. Yeah, for hospital workers, the mask has to be perfect because they're getting so much load. But for an average person who is not coming into frequent contact with high degree of virus, I believe that there's evidence to suggest that even an imperfect mask is better than nothing. Now, this is based on other viruses. This is not based on this particular virus. We haven't had time to study it. But the amount of respiratory droplets, even with a simple, cloth mask, can be dramatically reduced. We haven't done these experiments. These are based on the best possible ideas that we have. And it may be wrong, but the risk to reward ratio for something as simple as a mask is so high, in the sense the risk is so low and the rewards are so high that prudence would suggest that it would be a reasonable thing to do. And we do know that they work for other viruses, such as influenza virus. So taking all this into account, even though we don't know for this particular virus, in all honesty, I do think that would be a way to reduce the viral load. And if you can reduce the viral load, you may suffer a moderate to mild illness still, because you have been exposed. But that is much, much more easy to manage than the severe illnesses that require oxygen and ventilation.
Okay, that's put very clearly. It's a crucial solution, obviously. Must wear masks. It's as simple as that. Now, Siddharth, is there any other way to reduce viral load, reduce the virus in a person, and try and limit the spread of this coronavirus? Any other way besides masks? I mean, we're all worried about what will happen after the lockdown is lifted.
The second thing that would be very helpful is to do random testing. And by random testing is to go out into areas where there's likely outbreaks and stamp them out like you would stamp out local fires. That requires the kits being available and finding out where the outbreaks are happening, and try to get to those outbreaks as quickly as possible and socially isolate those outbreaks and put lockdowns locally, so that the whole country is not under constant lockdown. You see, what's going to happen is that once the whole nationwide lockdown is lifted, it's not as if the virus is going to go away. It's just going to start recirculating within the community. And so one lesson you can learn is that is the time when we should be doing very active surveillance and testing and figuring out if there are hotspots, isolating or locking down those hotspots, much like China and South Korea did.
That's very important. I don't think in India we've quite got that yet. We are doing testing, but we're doing testing in very specific, where there's a lead. But what you're talking about is randomized testing, because people can be asymptomatic, and they can still have the coronavirus, and they could transmit it. So if we could ask Dr. Devi Sridhar again, based on what you witnessed, the best way to handle all this is that, should you really have randomized testing, just try everywhere, and if a person has got it, whether they've got symptoms or not, it's a test, and do a lot of those tests all over, so then you can segregate and make sure it doesn't spread. Randomized testing, that's something India is not doing yet. Should we do that?
Yeah, so ideally, that's what you would have, and you'd have also surveillance in place, the level of transmission in different communities and different parts of the country. This is a virus that likes densely populated areas. It's probably less likely to spread in more rural areas. So if you can do surveillance, you can actually get an idea of how the virus is spreading, and that requires testing. So yeah, I think also what we're seeing is that, a first very good move is to test anyone who's symptomatic. So anyone who has a fever or a cough, or other associated symptoms with COVID, and then to trace their contacts. So anyone who could have been in contact with them, and then test them as well. And that's kind of a more strategic way of testing if you have limited testing ability.
Right. So wear a mask, and do randomized testing. Two immediate lessons that we need to really take seriously, which we learned in the last 10 minutes. Talking about, let's go to Chand Nagpal again. So you've been fighting a lot for more PPE, personal protective equipment for doctors in the United Kingdom, which even in the United Kingdom, that's in short supply. What about a poor country like India? Protective equipment for doctors. What message can you give from what you've learned for a poorer country like India?
India must plan, and we have also now resorting to domestic manufacture of protective equipment. So I hope that India will be ensuring that it has sufficient stocks because the pandemic has a huge demand on masks, gowns, eye protection, and so forth. And also there's a global shortage. So countries like China actually don't have enough to deliver to the whole world. So my advice would be, please look at having enough domestic production in addition to imports, because ultimately, if healthcare workers are not protected, they will fall ill. And if they fall ill, they won't be there to look after patients. It's probably one of the biggest issues for the medical workforce across the globe, which is shortages of personal protection equipment.
So, Dr. Nagpal, basically it's been more than 100 days since we recognized this as a pandemic. This crisis is much bigger than we initially thought. If you knew then, 100 days ago, what you know now, what have you learned in these 100 days and that would have changed your approach at the start if you had known about it and had this experience already?
I think the first thing is that any nation at the earlier stages should be expecting an unimaginable escalation of the virus spread in a way that can occur within days and weeks. So to plan for that worst right at the beginning. Now that means making sure that the nation is prepared with proper capacity and capacity that it may not have in terms of medical beds, ventilators, facilities. So in the UK, we have now opened up 3 new hospitals, converted a massive exhibition center into a hospital in London, for example. China did very similarly. So I think that the plans to really massively ramp up hospital provision is vital right at the early stages. Now, that also includes equipment, because, of course, the issue around COVID-19 is that patients need ventilation when they're seriously ill. And most nations will not have the equipment, readily available. So you need to plan to either import where you can, but there are worldwide shortages, but also look at domestic manufacturing. So we have in the UK used companies that have never built ventilators. I think, Mercedes, for example, are building ventilators for the UK now and repurposing manufacturing to achieve that. And I can't emphasize how important that is, because this condition in its stages of critical care require this sort of equipment. The third is testing. That I think many nations perhaps haven't done as well as China and South Korea.
Yes, I think these are really important messages. Thank you very much for those, and I hope everybody is listening. The decision makers are listening to what you're saying, because they're crucially important. If I can come back to Siddharth Mukherjee. Dr. Mukherjee, looking ahead, will it be possible for each one of us to get vaccinated against the COVID-19 virus? And how long will it take before we have a COVID-19 vaccine?
I believe that, and most people believe that this is a vaccinable virus. In other words, there are some viruses that you can't even make vaccines for. But this virus, I think you can make a vaccine for. The trouble is that vaccines take about 6 to 8 months at a minimum at the fastest possible rate. And the usual time is about 12 to 18 months. So we're looking at 12 to 18 months away for a vaccine for this virus. 6 to 8 months at the fastest to begin the trials, but even that is optimistic. And that's because vaccines are given to, as you very well know, vaccines are first given to high-risk, healthy individuals, and you're essentially giving it to a healthy person. So you have to be extraordinarily cautious and be very safe. And because if you have a side effect which might, be tolerable in a sick person, that side effect is not tolerable in a healthy volunteer. So vaccines are the best way forward, but they will take some time. The second thing that we can do in terms of strengthening immunity against the virus is antibodies. There are two ways. Either we use man-made antibodies against the virus, usually a cocktail of antibodies, and inject them and pretend as if your body has made them itself. I should tell you that that Kiran Shaw and I are in conversation with the Gates Foundation. There are 3 potential antibody cocktails made by 3 independent companies, and we're trying to open up the possibility of licensing those in India and having them available for India. But even that will take June and July. These antibodies are very hard to make. They are expensive. We have the capacity to make them in India, but as you know, the scale of the problem is so large that we may need to really accelerate our efforts.
Yeah, the scale. Is there anything apart from, this is a simplistic question, anything apart from a vaccine that can help build a person's immunity to this particular coronavirus or any virus?
There's nothing aside from a vaccine or as I said, giving passive man-made antibodies that will build up immunity. In extreme cases, in a very small study in the United States, we've taken basically antibodies from a patient who's recovered from COVID and transferred those antibodies to a patient who's severely ill. And that has actually shown some good effect. We have a trial with a company called Selenkos, which I'm a part of, in which we're giving a particular kind of cell into the body to raise immunity. Another trial with a company called Myeloid, which I also advise, in which giving a separate kind of cell to build immunity.
Right.
But these are in early stages. Sorry. We're still trying to find out.
Yeah. So just wanted to ask you, how difficult and how complex is it going to be to produce a vaccine? We know so little about this virus in the first place, and now it's a pandemic that hit the world without warning. So is it going to be very complex, much more than earlier?
I'm very confident that we can make these. This is a simpler virus to some extent than HIV because it doesn't. HIV, remember, causes a chronic infection that attacks the immune cells. This virus causes an acute infection that doesn't tend to attack the immune cells. Eventually, it attacks the lungs and kills off a lot of cells. But so I suspect that the chances that we will get a good vaccine or antibody or small molecule drug against this virus is quite high. But it takes time. It takes weeks, and it takes preparedness. So the message of hope here is mask yourselves, glove yourselves, use hand hygiene, and let the doctors be safe, because the doctors are the ones who are going to be running the trials to figure out if these new drugs work or not. Exactly right. Thanks. Let me just bounce that off Vijay Raghavan. You've just heard Siddharth Mukherjee saying a vaccine will come, a cure will come. Very positive about that. Time factor still could be 12 to 18 months. What's happening on that front globally and nationally?
Well, it's pretty exciting. And I'm just looking at a list of what I have, and it's pretty impressive. There are over 80 projects for vaccines.
Interrupt. I just wanted to add, we also talked about the vaccine with Siddharth Mukherjee, and he's saying that he's working with Kiran Mazumdar Shaw and others and other people in India like her to try and find a vaccine. There are lots of developments of the vaccine in India. Could you describe that to us, the vaccine in India, how many people are working on it, and globally as well?
Oh yes, there are incredible developments for the vaccine both in India and globally. And as I was just doing a count today, there are over 80 projects for vaccines. Now, again, it's important to understand that a vaccine is a tough haul, and when you buy 80 lottery tickets, you are almost certain to succeed. And this is really exciting. That so many lottery tickets have been bought, and in so many diverse ways. What are the diverse ways? One simple way is what is called using the virus's genetic material, encode that synthetically, and put that into humans so that humans start making the viral protein, one viral protein, and raising antibodies to it. So this is called a nucleic acid dependent vaccine, an RNA or a DNA vaccine. So there are several groups trying that. Zydus Cadila in India is working on a DNA vaccine. There are 13 groups working on an RNA vaccine elsewhere. The classical way to make vaccines is to inactivate the virus. Not really a classical, one way is to inactivate the virus. So use the inactivated virus to inject it and raise antibodies against that, raise the immune system to respond against that, and have that as a vaccine. Again, companies are doing that. A third way is a very interesting way, which involves genetic engineering. The virus is quite cunning. It uses letters in its genetic code, which are similar in frequency to what we use, so that our machinery can be used to help it translate its genetic code. But if you alter the genetic code in such a manner of the virus so that it makes the same proteins, but it's not as frequent as the code used in us, then you can use such a DNA or RNA vaccine to limited levels make the virus proteins. It doesn't overwhelm our system because it's not so efficient, and then it can serve as a vaccine. So this is called a de-optimized nucleic acid or DNA vaccine. And that, again, some companies are working on. And that's really something which shows a great promise. And the Serum Institute from India is working on that. Bharat Biotech, which made the rotavirus vaccine, the Rotavac vaccine, which was made in India, discovered pushed by Dr. Bhan, who sadly passed away recently, is looking at a self-limiting influenza vaccine. So it's a weak influenza strain in which you put the coronavirus gene in so that it's not virulent, but it serves as a vaccine.
Right.
Then, you can use other viruses.
I mean, what I'm just understand, this is really heartwarming to hear that there are so many different experiments and so much scientific work going on. That's really good to hear. How long do you think it'll be before we actually have a vaccine that we can use?
Well, and there are several other Indian companies also working on this, and there's a major push from the government on this. Now, globally, again, we've been looking at a list of what's happening, including in India. And it looks like, some of them, at least 2 or 3 of the vaccines are already in what are called phase 1 trials. They will then go to the next level of looking at the efficacy and safety and usability on populations. So those ones will hopefully by the end of the year will already be ready if they sail through those processes. The others will come mid next year. So the vaccine front looks promising.
Right, that's lovely to hear. Great, and I mean, India could be quite at the forefront of that from what you're saying. I'd like to bring in Lalita Ramakrishnan now. Everybody's familiar with the BCG, and there's a lot of talk going around that most Indian kids have had BCG, and so that's going to be a real help in warding off the coronavirus. Since we've all had BC vaccination at some point. So what's your view? Can it help ward off coronavirus?
Yes, unfortunately, there were some studies that there was one or two, maybe just one study that came out that compared the rates of viral infection in populations that had had BCG and had not, and they seemed to find a difference. And these kinds of studies are very suspect because there are many, many variables that will change this. BCG vaccine has been shown to protect against very severe childhood forms of TB. So it gives a temporary protection for infants and very young children from getting tuberculous meningitis, which is a terrible, terrible disease. And this is why, with very good reason, we continue to use it. The West has by and large doesn't use BCG anymore, but countries that have a lot of TB, we do this. However, those same kids who got vaccinated, once they become adults, they're no longer protected from TB, because if they were, we would not have 2.8 million cases of TB in India a year, right? We don't get any smallpox because it's protected. So now, coming back to this, why people have been jumping up and down about BCG in COVID-19. Some very interesting epidemiology many years ago showed that infants who got BCG had an overall reduced mortality from infectious diseases. So, all-cause infectious disease mortality went down even by as much as 50% in children who had been vaccinated as babies. And again, this was short-lived. So the feeling was that BCG gave this just general protection against all infections, sort of by revving up the immune system. You can think of it as just literally rev up your immune system so it can fight anything better for a short amount of time after the vaccine has been given. Okay, so there are two caveats with then immediately applying this to the question, the assertion that BCG vaccination is going to protect Indians against COVID. Number one, the protection for these other infections and for TB with BCG, as I pointed out, was short-lived. So the kids got protected only for a year or two, or maybe 3 or 4 years, both against disseminated TB and meningeal TB and against these other infections. Second point, it's not going to help people 50 years down the road. But there's another very important point that was made best by a very a fine colleague of mine called Kevin Erdahl. And Kevin gave this interview to Caravan. Kevin is a fantastic immunologist. He's a pediatric ID specialist, and he is a TB researcher par excellence. And when Kevin was asked this, he pointed out something really important, and that is that when you die, how does COVID-19 kill you? It kills you because you have an over-exuberant immune response. And this is why you're dying, because of a out-of-control immune response to the virus rather than the virus itself. So it makes very little sense then, rationally, to think that BCG, which mainly seemed to protect by revving up the immune response of children, to protect you now, because if anything, it would rev up your immune response and have the opposite effect. And so he would advise a great deal of caution in using BCG, and I would concur with his viewpoint.
Well, I tell you, that is a fascinating explanation, because, there's so much fake news and fog and mystery around it. It's lovely to hear a precise recommendation from you. I want to ask you, if a person gets infected with coronavirus, it could come from anybody, anywhere. It's virtually impossible to know which particular person gave it to you. In fact, doctors are saying, don't even try to identify where you got it from. That often leads to unproductive kind of, pointing fingers and wrong information. In fact, the opposite is important. minute you get it, let the authorities know every single person that you have been in contact with, right? Don't search for who could have given it to you. You'll never find out. Tell the authorities how many people you've been in contact with and you could have given it to, or they might have given it to you. Let them check everybody. Is that right?
We live in a modern world. The virus can come really quickly. And so looking for individual sources is not going to be helpful. Looking for pockets of infection is going to be very helpful, because what you want to do is not so much as blame those people, but it'll give you a sense of these are the kinds of exposures that is transmitting the virus. And you know what we're finding from the epidemiology in China, Singapore, Germany, US, UK, and Seattle, for example, is that you're getting that you do need fairly, you need close quarter exposures. It can be just talking, but it's not going to be passing someone on the street. Passing someone on the street is not going to do it, but talking to someone is going to do it, especially in a closed area.
Interesting, very interesting. Thank you very much. Let's quickly just get back to the economy for a minute, because today, Friday the 17th morning, the Reserve Bank of India announced some new measures. If I can get Gita Gopinath in, not specifically about those measures, but the way you describe it and the way everybody describes it, the shock to the economy, global economy, is so big. How are you seeing this very differently from any other crisis, economic crisis you've witnessed?
It is so. It's remarkable. Again, not in any of our lifetimes. It's in terms of our request for financing requests that we are receiving. Again, unparalleled, has not happened before. And the second is the speed with which the requests are happening, which means that we're getting multiple requests all at the same time, and we have to respond as fast with the resources that we have. And then I would say, even from my perspective, in terms of coming up with forecasts and projections, the uncertainty is just off the charts, and which is why we're very careful in our report to talk about specific scenarios, the baseline, the alternative. But again, there is too much a fog of uncertainty. So I think the way I think of this crisis is that it's a pandemic crisis which brought about the great lockdown. And it has three features, which is the speed with which you had a collapse in activity, the scale of the collapse in activity, and the tremendous uncertainty about what comes next. And I think with policy, too, it has to react the same way, which is it has to be very rapidly deployed. It has to have a large scale to match the scale of the crises, and it has to be speedily recalibrated as new data comes out.
Well, actually, the IMF has forecast that India growth rate will slow a lot this year, but it'll bounce back. We're talking about IMF projection of about 7% GDP growth for next year, 21, 22. I guess that depends on different assumptions, as you just mentioned. But what's the next key step for the global economy that the IMF is looking at?
So, from our perspective, of course, our main job is to provide concessional financing to countries who need them. So, we are looking at a large number of developing countries that have approached us for financing, and that's the number one priority. And we've scaled that up. So we've scaled up the rapid financing that we're doing, so that we can get the 100 billion that we need to help the different countries. The second thing that we're doing is on debt service relief, because we have many of our members who are having to, provide debt, pay their debt payments at this point, so they're not in default. And so we are providing debt service relief, and we've done that for about 25 member countries at this point. And we're calling, obviously, on many other IFIs to do the same. And the third, we are thinking about short-term liquidity lines, which is also, would also be something that would help with this crisis, because there are many countries dealing still with liquidity issues. So that's another, facility that we're looking at. I mean, at this point, we have all hands on deck, and we are exploring all the possible options we can have to help.
That sounds really quite
countries.
different, because normally the IMF is very stringent. It's got a reputation of loans with huge conditions. Are you relaxing most of those stringent conditions now in this crisis?
So Prannoy, with this rapid financing facility that I talked about is one where the conditionality is not it's very fast, it's very rapid, and there's very little conditionality.
Right, the big change. If we bring in back to medicine and bring in Dr. Devi Sridhar. Doctor, if you look at the countries and you looked at across the globe, so many of them, which ones have done well and which one have not done well? Now, India is a developing country. We don't have the resources and the financial cushion that the West has. Give us a couple of tools that India should use and implement, and a couple of things that India should not do, must not do.
Well, I think the most important lesson we've seen is to try to contain the virus as much as possible and keep numbers low, because it's exponential growth and it's much easier to be in a position where you're dealing with dozens of cases or hundreds of cases than if you're dealing with hundreds of thousands of cases. And that's a lesson from countries like South Korea, Australia, New Zealand, who have managed to keep their numbers quite low. It's still a challenge for them, but I think one clear lesson is containment is very important. I think another lesson is to build diagnostic capacity. Yeah,
sorry, you said containment. I just wanted just a little more description on how do you do that containment? How do you suggest?
Containment by just actually testing, tracing those individuals and putting them into quarantine. And so actually just trying to manage the number of people who are affected by this virus. I think a second lesson is about diagnostic capacity. South Korea knew from its experience with MERS that actually lab capacity to really ramp up testing capacity and the number of contact tracers, the number of community outreach. And I guess the third tied lesson to that is actually the importance of a decentralized response, that this is about local communities. This is about local governments, and actually making sure that even if it's centrally coordinated and overseen, that actually there's local response and that they have, local accountability and responsibility. I'd say things not to do. One is, I think it's quite dangerous to spend too long in lockdown. Lockdowns have been seen as a solution in terms of you can rapidly reduce the rate of transmission, but lockdowns are very costly socially and economically. And so every day in lockdown has to be used quite valuably to actually try to aggressively go after the virus. I think another one is just to try to buy time for a scientific solution, because it'll be science which really gets us out of this kind of global crisis.
Right. I guess buying time is important because, as a developing country, you don't have so many doctors and facilities that the West has. But what is the alternative to a lockdown, and how do we get out of it? What are your thoughts on that?
Yeah, exactly. But that's why I say I think lockdown was probably essential to get a handle on it, but using that time, because one of the benefits of lockdown is the number of of contacts one person has seems to reduce, right? From, more than 20, maybe more than 50 to actually less than 10. And so if you actually want to do, aggressive testing, if you want to do surveillance to understand in the country which populations have, higher transmission, I think this is the time to do it. So lockdown basically is like freezing time, or putting kind of, pause on this rate of transmission of the virus while you implement other measures. And so the time should just be used as much as possible to aggressively go after the virus.
Let me just ask you about one controversial recommendation, which is been suggested and then they've been kind of redacted or not exactly accepted, is that in a lockdown, when you lift it eventually, you should still carry on with people 60 and above still being in lockdown, and no lockdown for people under 60. Does that make sense, or are there problems with that because the younger people will go out and then come back, perhaps, especially in a country like India, with joint families come back and interact with people over 60?
Yeah, so this is being discussed in a number of countries, the idea of shielding certain vulnerable populations. And I guess at a conceptual level, it makes sense. But the thing I guess I worry about also is how much can you shield these individuals, because you have multi-generational households. You often have, elderly people living with children, with their grandkids, or with family members. And so in a perfect world, if we could, find a way to do this. And the second thing I think is interesting talking to elderly people is many of them say actually it's very important for them socially to see other people. And that loneliness and social isolation is also not without a cost. So I think that has to be weighed, not first in terms of is it pragmatic, can you do it? And the second is actually, do those people even want that as a possible solution for them? They have to be listened to as well.
Yeah, very well put, actually. Thank you. I'm just going to go back to Siddharth Mukherjee. Siddharth, it's going to be, as you said, quite a long while before we have a vaccine. In the meantime, you said social distancing, wearing masks, washing your hands, etc. Is there anything that people can do, like keeping fit or getting fit, which will that help fight the coronavirus and win in some way or the other when you're in trouble? I'm doing an hour of yoga every day for the first time in my life, and jogging and gymming, etc. Don't tell me that's all a waste of time. Does yoga and exercise, do people listening to you, will it help them if they get fit?
What it will build is, I think it's important to remain healthy, because immunity is one thing, but when one of the things that's happening with severe infection is that your heart and lungs start failing. And so it's important to keep your heart and lungs in good shape, aside from your immune system, to make sure that they can resist the physiological damage that one has once you get a severe infection. So let me be the first to say that yoga and a jog won't change your immunity, but it will keep you in better health, and that better health in terms of your heart and lungs and kidney will serve as the final buffers against the physiological damage caused by this virus.
So as a message to everybody, it is important to get fit, do yoga, jog, whatever, even if it's in the same place. I keep telling you about that Italian gentleman who ran up and down his balcony and did a marathon. He did it so many times. He ran a marathon. But Siddharth, what do we learn from the data in America that's beginning to show that children aren't getting it that much? And it also showing that African Americans are getting in a much higher proportion than others.
Well, so both are mysteries. The fact that children are not getting it more is a mystery. Children are more likely to be asymptomatic carriers, and in fact, this behavior has been seen with other viruses as well, in which we've seen that children often get a milder case. Chickenpox is a good example. Measles is another good example. Children get a milder case. As far as African Americans in America, we don't know. It may be genetics. They are also African Americans and Hispanics are also people who are essential workers. They're in the subway now. They're delivery. They're doing a lot of delivery just because of socioeconomics. So it's very hard to break apart the socioeconomics versus the genetics at this stage, and we just don't know the answer.
I'm going to take this opportunity to clarify points exactly like that. How much evidence is there? For example, there is a kind of underlying hope everybody in India has that it's summer's nearly here and temperatures will cross 40 degrees centigrade, and that heat will kill this virus, or it won't spread nearly as fast. Is there any truth to that kind of hope?
And we don't know the temperature issue, although we now know that other countries that have been hot at this time, like Brazil, in the southern hemisphere, are also getting infections. So I'm afraid we don't know. And the initial hope was that, generally in very hot climates, hot and humid climates, the virus doesn't survive very well. Coronaviruses as a family don't survive very well. This virus may or may not. We just don't know. We don't know the answer.
Okay. President Trump and many others actually seem to think that hydroxychloroquine could be a possible cure for this virus. It's a tablet that's been used for years against malaria, and India manufactures lots of hydroxychloroquine. Do you agree? Is there enough evidence that it could be a cure for coronavirus or a prophylactic, and should one take it, or is it risky? Can you clarify that for us?
There are a couple of trials that have attempted to use hydroxychloroquine for COVID. They are of, most of the cases, I would say that the trials have been of very poor quality. So the evidence that hydroxychloroquine works in this disease is of very poor quality. It also has, as you very well know, lots of side effects, including the possibility that you would increase your risk of cardiac disease. So unless you're part of a clinical trial, I have not been recommending anyone to take hydroxychloroquine. The data is not convincing enough.
Should not have it. Okay, that's very important to hear that from you. Let's go quickly back to England and Sachan Nagpal. So just to ask you about testing, there's so many different types of kits from different companies. Some are very well-known companies, not so much. There's this rapid antibody testing. There's this new NAT testing. What should a country do? I feel that England made a bit of a mistake. We in India are using the normal PCR test, which is a little expensive, takes long, but it is a good test. But can it be used for, hundreds, millions of people? And England made a mistake in ordering. What have you learnt that India should take into account in ordering different types of test kits?
I think it's really important with any test kit to make sure it's validated. There's been reports of many kits that have had high levels of false results, and that is, what you don't want is to give false information and then take public health decisions on those false readings. Sometimes error rates of around 30%. So it's important that any nation properly validates and checks the accuracy of tests before making it widely available.
And now, of course, this 30% kind of error rate, the test can be very good, but the sample method of collection that you use a naso and throat swab, that's not done too well, so the test cannot actually, so it's not just the test, it's the way you actually collect the sample. But finally, Sachan Nagpal, are you more optimistic now than you were, say, a month or two ago? And how long do you feel this crisis will last, in your view? That's an unfair question, but would like to hear that from you.
I don't think any of us can take a view about being optimistic. That would be providing false assurance or complacency. We have to take each day as it comes and give our fullest attention and efforts in addressing this virus. It wouldn't take long, for example, even if you had suppressed the virus, for it to come back if there was any relaxation on the public health measures to shield, to isolate infection and so forth. So there is no room for complacency or optimism at this stage. So as I said, we are still in the UK planning to expand our capacity for patients requiring hospital admission. That surge can occur in a very short period of time. The other thing is workforce, because this pandemic is, creating an enormous demand on medical workforce, doctors, nurses, other healthcare workers. So in the UK, we have brought back significant numbers of our retired doctors to come back and contribute to supporting the workforce. Medical students have also been fast-tracked in their final years of education to become doctors, to add to that workforce.
So in all your planning that you're doing right now, how long are you planning for this crisis to last? Preparing for the worst, and how long would that be?
Well, it's certainly not going to be over in the next week or two. We've actually got our highest risk patients, some of our most older patients, those with severe underlying medical conditions, who have got a 12-week shielding arrangement where they are literally going to they are staying at home and not even communicating with anyone else, because they would be at greatest risk of serious illness. So we're planning for months. I think that there may be, if we are fortunate in many nations, we may see some relaxation of the levels of social isolation. There may be some opening up of work, but that's not going to come, I don't believe, in the next week or two. It may be in a few weeks' time. And even after that, it would have to be done in a very graded way. And I believe that mass testing, will have to continue. And I hope by that stage we've got the antibody test, because even if you feel that that you're through the worst, it's important to keep a measurement and monitor the level of infection in the community should it start to increase again.
Right. Let me just ask the same question to Devi Sridhar. Dr. Sridhar, how long do you think this is going to last? Unfair question, but I'd like to hear it from you.
So I guess the bad news is that this virus is going to be with us for a long time. I think it's going to be with us for months and possibly years. Some of the modeling is showing till 2022. Another paper out yesterday said 2024. I think what we're all waiting for is some kind of scientific breakthrough. So the race is on for a vaccine. That would be huge if we can get a vaccine that's effective, that's affordable, and that's made available to populations across the world. So that would mean one thing that could speed up actually how we respond to this. Another would be some kind of therapy. So an antiviral therapy, either taken at an early stage when you have the virus, so an early stage of the disease, so to stop having severe symptoms, or when you have severe symptoms to prevent you getting critical, or at a critical stage to prevent someone from dying. And a third is a rapid diagnostic. We still don't have a great, cheap, fast way of actually testing people if they have the virus. This needs to be done now in PCR labs, and it can take, again, even in the UK, it can take days to actually get your result,
Right.
and it's quite time intensive. Yeah.
Very correct, yeah. Actually, the reason why I'm asking how long this is going to last, because India's at the moment at a very crucial, critical point, and that is we are currently just at the beginning of our harvesting season for the Rabi crop. And, we're going to start planting for the Kharif crop a little later, soon the rain starts. So if I can ask Professor Bardhan, how should one handle it? There's this killer virus, there are landless laborers that are out of jobs and they need the money. How should a country like India tackle this? Because it's crucially important for India that the harvest goes well, that the crop is harvested and goes into storage, or at least used to feed people. And basically, hundreds of millions of people are dependent on this harvest right now. How to handle it?
Right. It's the Rabi crop season, and there may be a labor shortage in some areas, so that has to be made sure there's sufficient number of people working there, and of course some of the migrant workers manage to go back home, so that would help in the harvesting the crop. And also the employment surveys are showing, of course NSS surveys are not available anymore, but the CMIE survey shows that in the last 2 weeks a very large percentage of the workforce have lost jobs, and that is also in the rural sector. So, and quite often people have dropped out of the labor force. So you have to mobilize these people both in the NREGA program and also in harvesting the crop. But quite often the farmers are worried that even after they harvest, they might not be able to sell them. And that is a major issue of trying to organize the going around the traditional mandi system, trying to organize direct selling by farmers to outlets, the buying outlets, and so on. This is a major issue of marketing to me, will also affect
that's the
which
key point,
the
actually.
farmers are going to harvest the total crop.
Right. The role of the Food Corporation of India, the FCI, is very important right now. All those go-downs that they have bursting, and now more harvest, rabi harvest, the wheat crop is going to come in, the food grains. I mean, it's crucial that this harvest is done. The FCI has a big role to play, isn't it?
Yes. FCI, I'm told, has now already about 77 million tons. Now, if the rabi crop comes, where will they store them? So I think it's immediately very important that FCI releases those things that are stored there and go into essentially a universal public distribution. Anybody who wants food will get food, no matter what, no matter where. So that way, the FCI warehouses will also get some storage space for the new rabi crop to come in.
Right, that's really, really important. And as we're coming to the end, and it's been absolutely, I've learned a lot in this whole, I know it's been in depth, but you can't get better minds giving you clearer messages in this circumstance. So I'm really grateful to all of you. And Dr. Devi Sridhar, what's your final message for an emerging market like India? Anything specific, any specific message?
Yeah, I guess it's to say that not to underestimate the challenge this virus will pose for the coming months and years. This is a crisis that's different to an earthquake or a hurricane. This is not time bound and it's not geographically bound. And that actually you have to really take a long-term view to addressing this. And that actually what might seem very costly or very difficult at the start. So mass testing, mass tracing, large-scale quarantine might end up being the most effective, strategy in the long term, because this is going to be with us for months, and there has to be a better way than just locking down societies or letting, thousands or hundreds of thousands of people die.
Thank you very much. Very, very important points you made throughout. If we go to Dr. Lalita Ramakrishnan, finally, from all your studies and your analysis and on-ground experience, what kind of message or what kind of direction would you like to give people on how to handle this pandemic crisis, particularly in India?
If I had one message, I would say that this is the time to band together.
Right.
And by that, what I mean, I don't mean this in some sort of Girl Scout, Boy Scout kind of manner. I'm talking about the fact that, let's take the case of India or the US or the UK. There's amazing talent, clinical talent, public health talent, research talent. But this talent is distributed. It's distributed amongst multiple parts of the government sector. It's distributed quite a bit through the private sector. And I think that we have to be really careful not to have a sort of top-down control about who gets to decide about coronavirus, who decides to work on it. Similarly, public health measures have to be, brought from everywhere, both different government agencies and non-government agencies. The private sector in India, for example, I do much of my TB work is done at the Christian Medical College, Vellore, and they are incredible. They're incredible clinicians. They do incredible clinical research and have a long history of it. So, for example, DJ Christopher, who is the head of pulmonary medicine there, is, he's one of the, best pulmonary doctors in the world. These are the kinds of people that would be, that should be brought immediately into the mix. then, again, pointing, to CMC, because I know CMC best. You have someone like Gagandeep Kang at the CMC who, ran the rotavirus vaccine trials. So, and has done a lot of work at the interface of public health and transmissible disease. So,
Absolutely.
she's someone who should be brought to the fore. So
Right.
I think it's really, really important to engage,
I think,
just about anyone you can.
yes, and band together. I think you're absolutely right in that message. And to some extent, India is doing that. I think there are a lot of positive feelings that people are coming together. The private sector is doing their bit. Everybody is trying to help each other to a large extent. There are, of course, always anomalies, but even politicians, anybody who's using this crisis for political gain is losing out terribly. So there is a banding together. I think that message you gave is very, very, a very good one. And to some extent, it's happening in India, which is wonderful. Same question to you, Siddharth Mukherjee. Final thoughts and advice for India?
Well, I've gone through all of them already. Just to summarize them again: isolate, distance, masks, hygiene, and random testing in order to figure out what the real rate of infection is. Especially if the lockdown is going to be opened, it would be the time to stamp out local flares of infection.
You're right.
Right. And keeping people as informed as possible, giving them information and preventing the spread of false information.
And a personal question, as a doctor, you're a doctor on the front line. How are you looking after yourself? And do you have a message to all our doctors, who many of them have read your different books, but like you are risking their lives and their families' lives for all of us?
All the ways that I'm wearing protective gear. I'm socially isolating and distancing. Any members of my family, thankfully, no one has been affected. But we are trying to limit contact. And as I said, I'm also working very hard to try to make some of these medicines that are arising, make them available in India as soon as possible.
Making them available in India. That's wonderful to hear. Thank you so much for being with us and spending this time. And also, Gita Gopinath, thank you for spending this time. And a personal question to you as well, just like that. How is this crisis? You're not a doctor of medicine, but you are a doctor of economics. How has this crisis changed your daily life?
Yes, no, it's changed in a way that has never ever been the case in my lifetime, and probably not in your lifetime either. My son goes to school at home. We've had to do, this is the busiest time for the International Monetary Fund, and we cannot all be in the same room, and we cannot, discuss these things. In previous crises, we will be flying to different countries, sitting down with people, coming up with solutions, but now it's all done online. So it's very, it's been very difficult, I would say. And but at the same time, this I think will change the way we live going forward. I can see very well a situation where we do much more meetings and conferences and seminars online as opposed to in person. And that might not be so bad for the climate.
So Gita, you are working hard for once in your life at last, right?
It's a challenge. It's a challenge.
Yeah. Working hard is a
big
challenge.
And it's not going away anytime soon.
Right, exactly. Thank you so much for joining us, Gita Gopinath. Thank you all for being with us. I hope you learned as much as I did throughout. I must thank all our panelists and guests for spending. This is the busiest time of their life. You cannot imagine how busy they are, and they spend all this time with us. And thank you also for watching. Bye-bye for now.